this meeting of the Kittitas County Public Hospital District Number 1 Board of Commissioners to order. Yay. All right, so well, I like that. All right, so first order of business is the approval of the agenda, or anything that anyone would like to pull from the consent agenda. Any additions, changes to the agenda? Hearing none, I have a motion. Okay, second. Motion to approve the agenda. America, second from Liana. All those in favor say aye. Aye. Okay, that's unanimous. All right, consent agenda includes minutes from the last board meeting, regular board meeting, and the recent special board meeting. Approval of checks, foundation report, minutes from the finance committee, and the UI council. Any questions about the consent agenda?
I move for adoption.
Okay. Second. Moved and seconded. All those in favor say aye. Aye. Unanimous. All right. Now on to presentations. We have the Safe Catch Awards. Mandy Olson.
Yeah, I'm going to stand up today. But just to remind folks what a safe catch is. It's a catch prevented an event from reaching a patient or staff member, prevented pain, delays in care, unnecessary costs, or workflow inefficiencies, was high risk or had potential for greater patient harm, such as communication errors, surgical site infections, or falls, led to frontline or just-in-time improvement. So tonight we actually have three groups that are awarded. We have 2 clinical award winners and a non-clinical award. So someone who works in a clinical capacity caring for patients, and then those who work more in an office setting or don't have a licensure. So for the clinical award, our first winner is Heather Zeck. You want to come up while I read that? She was nominated by Dr. Mark Lyerson from Minnesota, who's also here. A patient was scheduled for a total knee replacement, which also required this patient to have a treadmill test prior to surgery. The treadmill was scheduled and was to be supervised by Dr. Larson. The patient arrived for her test, but Heather was uncomfortable with the patient's safety due to the patient's ability to walk, secondary to her knee arthritis. Heather called the clinic to confirm the necessity of the exam and was told it was needed. Dr. Larson showed up, and again, Heather said she didn't feel it was safe for the patient to walk. The doctor pushed back and talked about how the patient needed the study to get her surgery. His words. The following week, he spoke with anesthesia and cardiology. Anesthesia would not do the surgery without a stress test. Heather felt strongly enough that it was not safe, and between Heather, the patient, and Dr. Larson, they came up with a different direction to cancel her surgery and have a cardiology consultation. If Heather had not stood up for what she felt was a patient safety issue, the patient might have been injured while doing a treadmill. The patient subsequently has been cleared by cardiology and is rescheduled for knee replacement. So thank you very much, Heather. Okay, so now we have a trio of folks who have won this award. It's Ryan R., Jim Rupture, and Dr. Tom Mirich, who are all here. If you want to come up, I see while you're all up here, the team. So they were nominated by Tanner Sheed, the clinic manager for ortho, general surgery, and workplace health. So on Sunday, February 25th, the patient was seen in the emergency department for an injury that happened at work. The patient had an x-ray done and on his chest and diagnosed with a chest injury. On the 27th, Ryan saw the patient in workplace health. The patient's condition worsened, and Ryan referred the patient back to the emergency room. The patient was discharged after a repeat chest x-ray on the chest. On the 28th, Jim Rupture saw the patient in the orthopedic clinic. After consulting the providers in the clinic, Jim decided to send the patient to the emergency room for a 3rd time. Jim called the emergency room provider to get a CT scan of the patient's chest and possible inpatient admission. On the morning of March 1st, Jim and Ryan reviewed the CT with the consult from Dr. Mirich. Ryan was advised to talk with cardiothoracic surgeon. Ryan spent hours arranging for the consult. After the cardiothoracic surgeon from Harborview called Ryan back, Harborview accepted the patient as a trauma patient. So kudos to these 3 providers that persisted to catch a potentially life-threatening condition. card to McDonald's. So very much.
Thank you.
Yes. Okay, our last one. I'm going to put a picture up here because it is also going to be a patient story that's going to come out really soon. So I will read the patient story actually that's going to be published. Thank you, Michelle, for getting this to me. So Summer Hathaway was panicked. Standing on the shoulder of Kittitas Highway, holding her unconscious baby in one arm, she tossed things out of her van with the other in a desperate bid to attract attention. Cars flew by, drivers seemingly unfazed by the scene unfolding on the side of the road. When a stranger pulled over and uttered words Hathaway will never forget, "What can I do?" The stranger was Kittitas Valley Healthcare Sarah Martin, patient service representative by occupation, Good Samaritan by inclination. It happened late on the afternoon of March 3rd. Hathaway, who lives in Kittitas, was driving her then 15-month-old son Alaric to the emergency room at KVH Hospital. That day, Alaric had come down with a rash and fever, the same symptoms he had before suffering a seizure that shut down his airway during a visit to California 6 months earlier. Hathaway's 19-year-old son, Tristan, who has Down syndrome, was riding in the back with Alaric when he told their mother Alaric was sleeping. "I heard the baby gasping for breath," Hathaway recalls. "I pulled over. I called 911. Enter Martin. "As I drove by, I saw Summer just throw the stroller out," she recalls. "She was moving really fast. I just knew something was wrong. It was a gut feeling. My mom has always told us since we were little, trust your gut. It's usually right. I knew there was no way I could drive by and keep going and be okay with it. It would have haunted me if I could have helped and did it." So Martin turned around at the number 6 road and came back around. Neither a nurse or a doctor, Martin didn't know what she could do, so she did what for her comes naturally. She opened her arms and her heart. Standing on the side of that road as vehicles rushed by, she held Alaric and talked to him. And when the paramedics arrived to transport Alaric to KVH Hospital, she offered to drive Hathaway's van, an offer a grateful Hathaway declined. "Once I handed him off to the paramedics, I was calmer," says Hathaway, who continued on to the hospital with Tristan. And Martin, calm and determined to do whatever was needed when she stopped, emotion overwhelmed her when she went back to her car. "I just broke down in tears. I just wanted to hug my boys," says Martin, the mother of 2 young sons. As for Alaric, he was treated in the KVH emergency department, then airlifted a couple hours later to Children's Hospital in Seattle. "The KVH emergency department was amazing," Hathaway said. "The staff communicated with us and really showed they cared. They were taking care of us as well as Alaric." Since that day, Alaric, whose parents called him the miracle baby they were told that they would never have, has been in and out of Children's. Diagnosed with Chiari malformation, a condition in which the brain tissue extends into the spinal column, he may be headed for surgery. He's also been diagnosed with epilepsy after another seizure in early April while in Seattle. In the midst of dealing with the challenges Alaric faces, Hathaway says she will never forget Martin's kindness. I had a half-naked, unconscious baby in my arms and everybody was just going by," she says, her voice emotional. "I think I would have been out of my mind if Sarah hadn't stopped." The best part of my job and QI Council, I think.
It's true, yeah, at the QI Council we get such a warm feeling and it makes us feel so proud of our employees. Thank you all for coming and for the great work you do. Thank you. Okay, next on the agenda, Julie Peterson talked about alternative payment models, and I believe we have the copy of the PowerPoint.
And I have asked all the people around the table who helped participate in this process to jump in at any time. So, and it's more than just alternative payment models. I feel like over the last couple of years, a piece at a time, we've talked to you guys about things like the ACOs and what's going on with the Accountable Communities of Health. And we really are at a point in all these initiatives where they're converging. So we thought it was time to update you and tell you sort of where we are and what we see coming. So the building blocks. The Affordable Care Act, first of all, in 2010, of course, one of the results we saw was an increase in Medicaid enrollment, but there also was a lot of encouragement through the Centers for Medicare and Medicaid Innovation and through HRSA to look at different models of care and to apply for grants and pilot programs to see how healthcare could be delivered differently. And then also on the state front, the Healthcare Authority moved to a position where they consider themselves the first movers for healthcare reform. They are the purchasers of 20 to 35% of insurance for Washingtonians. They include Apple Health, which is Medicaid, the PEBB, the Public Employee Benefits, and then also in 2018, starting in March, there's a real push to fold the School Employees Benefit Program into the Healthcare Authority. So they are a major purchaser in Washington State. Their stated goals are to build healthier communities through a collaborative regional approach, integrate how we meet physical and behavioral health needs, and improve how we pay for services by providing or rewarding rather quality over quantity. And then we also have a number, as the years have gone by, of public-private initiatives that we've been addressing. The BREE Collaborative we'll talk about later. That was created in 2011 by the state legislature to really look at quality. And they've had a number of initiatives that we have seen folded in. I think the 39-week was a BREE Collaborative. So they come up with ways to really eliminate variation and improve outcomes in healthcare. The Puget Sound High Value Network is a purchasing agency that's a model contract for the Healthcare Authority. The Washington Health Alliance holds itself out as really a judge of quality in practices and in healthcare providers. And then in our own county, we have the Kittitas County Health Network, which we pulled together. It's Kittitas Valley Healthcare, KVFR, CWU, the Greater Columbia Aging and Long-Term Care, the A-Team. We have the people at the table that we think can influence the social determinants of health and also address some of what's coming down from the Campbell's Community of Health. So, the Affordable Care Act, slow starts and why. So the two things I want to address out of the ACA, the first one is the Accountable Care Organizations, or ACOs. So ACOs we've been talking about them for a long time. It's a group of coordinated healthcare providers who form an ACO, who then provide care to a group of attributed Medicare lives. So you come together to influence referral, to influence care, and your organization then bears some risk for that care. So you establish a baseline as an ACO for all of those attributed lives of costs for the last 3 years, and it's a weighted 3 years. And you have an opportunity, if you perform better than that, to share some of the savings with the Medicare program. It's also called an MSSP, or Medicare Shared Savings Plan. Initially, as you go into this, it's upside only, so you can share on the upside. If, however, downstream your overall beneficiaries are more expensive than the benchmark, you could be in a downside position. The challenges to this, going back to 2010, is that in order to achieve an acceptable level of variation, an ACO has to have a very large body of attributed lives. 60,000 to 100,000 is about where they've landed, but there are people who say, initially they came out saying 5,000, and that was a disaster for early ACOs. There are some people who feel like 500,000 is the magic number. The IT systems were not set up to track costs across beneficiaries. We know what services are delivered within our own system, but we don't track it by Julie Peterson across all delivery systems and all providers. Determining how attribution would be made was very contentious. If they initially came out saying it would be done by dollars, which means you can see your primary care doc every week for a year. If you go to a cardiologist and have a procedure, you're attributed to the cardiologist. So they went through a number of iterations about how lives would be attributed to which ACO. Beneficiary costs from CMS lagged by a year or more, and I think a year is generous. So here we were supposed to be responding to these costs, and yet we couldn't get information for 12 to 15 months out. And it's always an issue to have a payer-specific delivery care. So here we are dealing with 30% of our population in one way and 70% of the population in another way. And that can be confusing as a care model. It's definitely confusing as a reimbursement model. So these have been around for a while. I think in urban settings and in very large systems, they've rolled them out and tried them. It was a real challenge in rural. because by definition, rural is not going to have 60 to 100,000 lives, Medicare lives, that they can attribute to an ACO. Next. The other thing that came out of the Affordable Care Act are what was called bundled payments. And a bundled payment is where a provider, and the first thing they had to decide is which provider was going to get the fixed fee, let's say, for a total hit or a total joint. So here's $50,000. You are responsible for pre-care, procedural care, and post-care, everything that goes into a total joint. So in these bundled payment models, the first thing that they had to address was who was going to get and distribute that fixed fee. Was it going to be the physician? They had a strong argument that it should come to the physician, and they'll contract with hospitals, anesthesia, nursing homes, diagnostic imaging centers, all the people they needed to deliver and distribute, contract for those services for that fixed fee. I think hospitals ended up primarily being the organizations that received these bundled fees. These were rolled out as pilots, and it's been really on again, off again with the Trump administration. Dr. Price, when he was the head of HHS, pulled all those back. There's some talk about sending them back out now. So that's just been on again, off again. It has a tendency for adverse selection. That is, you get the 6 people in a bundle like that, and other people are out, the younger, healthier folks are out shopping. So it does tend to poison the pool over time. And then again, something like this is not going to be a rural model. We can't go out and bid a variety of providers to provide these services on our community. By and large, there's one of everything. So, next. With the Healthcare Authority, in December 2000, and you've heard us talk about the SIM grant and the various grants that are going on in the state. In 2014, the state received a State Innovation Model, or a SIM grant, and this came to us through CMS. It was $64.9 million, and that grant was distributed to the state in order to establish the infrastructure that we need to transform healthcare in Washington state. So this is not about paying for Medicaid services. This is about setting up the committees and the transformation hub, getting the people together, designing the care that we wanted going forward. It is a 4-year grant, and it ends in December of 2018. Their theory is that most care is organized and delivered locally. So they divided the state of Washington into 9 regions plus the First Nations. And we had Carol Mosier from Greater Columbia come and talk to us a 1.5 years or so ago. She heads the backbone agency that supports the Greater Columbia. These are called Accountable Communities of Health, or ACHs. KBH is in the Greater Columbia Accountable Community of Health, and we have both Kevin Martin and Mandy Olson attending those. And Kevin has some hands-on experience with what those projects are, if you want to.
Yeah. Okay, if I steal your next slide.
Yeah, absolutely. Yeah.
So
welcome to the neighborhood, by the way.
Yeah.
This
Yeah.
is local care.
So Klickitat is shaded because when this slide was generated, it was planned to move them to Southwest. That's happened. What's left off here is we also have the Yakima Nation in our Accountable Community of Health, and it's an interesting definition of community. There are 3 domains that the ACHs were required to address. The first was health and community systems and capacity building. Everybody has to address that, and that includes value-based purchasing, workforce, and addressing population health. Domain 2 had 4 projects, one of which was required. Domain 2 is care delivery redesign, looking at systems to affect change. Everybody was required to do bidirectional integration of physical and behavioral health through care redesign, which no clinician came up with that title. But the idea was that you had to have access to primary care from behavioral health and vice versa. Project 2B was community-based care coordination, which our ACH is not doing because there were some troubling metrics with it, and it was felt that everything else they were supposed to do implied it. And so there was no financial hit for doing less than, there was no financial hit until you got down to 2 Domain 2 and 2 Domain 3. And so that's what the ACH decided to do. The other Domain 2 project that we're doing is transitional care, making sure that people are safe moving from hospital to SNF, SNF to home. That project is going forward. I'm the facilitator for that project group, and that will be fascinating. The other Domain 2 project that we aren't doing is called diversion interventions, keeping people out of the emergency room. Quite frankly, we're probably okay in this county that we're not doing that because we do better than most of the counties in the ACH at keeping people out of the emergency room unless they need to be there. The Domain 3 programs address prevention and health promotion. The required project is something addressing the opioid use public health crisis. And the other one we're doing is the 3D project, chronic disease prevention and control. The ACH decided not to address the other two Domain 3 projects, which were reproductive and maternal/child health and access to oral health, because those two projects had metrics that there's a defined set of metrics that you have to meet to get this money. And those two projects had unique metrics, whereas most of the other metrics are shared across 2 or more projects. And so it was felt that addressing those explicitly and making ourselves accountable for those projects jeopardized the whole thing.
But we could also address those issues as part of some of the other projects.
Exactly.
So we could include improvement to access to oral health or maternal and child health as part of transforming clinical practice.
So the funding model from the ACH is kind of fascinating because they stand to get $135 million if they meet all of the metrics that they're accountable for, and then how they spend that is up to them. So that they, by absenting themselves from maternal child health, they don't get penalized if they don't impact on low birth weight. But they can still choose to spend the money to support maternal and child health.
So what's critical is of that $64.9 million,
Rapid response.
we are not being reimbursed for providing services that way. This is all infrastructure that's going on. This is setting up the contracts, defining what the metrics are going to be. So by and large, that money's not moving through to either the MCOs, the managed care organizations, or providers. This is an infrastructure piece of it. So the next phase of this, however, is what's called the 1115 waiver, and that is a $3 billion waiver that the state of Washington has received from the Medicaid program. So the Medicaid program is very locked down and very prescriptive in what you can do, what benefits you have to provide, and who qualifies for Medicaid. As part of the Affordable Care Act flexibility, waivers like this allow a state to take that same money, and in this case a little bit more money, and spend it in a different way. So it waives the requirements of the traditional Medicaid program. However, and it is a matching program, so half the money is state money that we would be spending anyway for Medicaid, and the other half is the matched federal amount. The state is obligated to save 2% during the life of the waiver, and our waiver is 2017 through 2021. Again, we are not yet being reimbursed for providing care any differently than we were before we received this waiver. It includes some dollars that are not traditionally considered medical costs, and that's how we get the bump in the actual dollars that we get to distribute among providers. The work of the SIM, or State Innovation Grant, is what created the infrastructure to implement this 1115 project going forward. Originally, 90% of the state purchasing was to be value-based by 2019, so we're 6-7 months away from when 90% of people were supposed to be being paid for providing services this way. Thus far, we've only really been paid for project work. The way we're being paid for services has not changed yet. However, the Greater Columbia is considered a mid-adopter, so we were supposed to be on board in 2019. 2019 is now what they're calling their goal, if not their stretch goal. So they're having a hard time hitting some of these targets. We know that the funds are intended to flow through the managed care organizations like Molina and Community Health, those organizations that currently manage the Medicaid population. We call those MCOs. But the method and the metrics for how those funds are going to flow in the future have not yet been determined. As of today, and Kevin was hoping we'd have an update on this, but there are no contracts in place with the ACHs, with the MCOs, or with the providers. We don't know what the metrics are going to be, and we don't know how we're going to contract to be paid for these services in the future. Is that fair to say?
There are some payments that they're going to make built on building infrastructure and the project work, but not on the reimbursement for care.
That's the goal, but there's, as of noon today, no consensus at the ACH as to precisely how that will work, or indeed what will be incentivized. And to put that, the reason for that is that a lot of the metrics that the ACH is held accountable for are really about population health. And clinical care has a fairly small impact on population health. Probably 20 to 30% of the health of the community is directly attributable to healthcare. A much larger percentage, some would say as much as 50%, is social determinants of health. And a lot of the metrics the ACH is accountable for address social determinants. So if you're spending all your money clinically and expected to move the needle on social determinants, you're going to fail. So there was kind of in the work group today, there was a recognition that perhaps if we're supposed to do things that we can't affect clinically, all the money shouldn't be spent on clinics.
Yeah.
The payers we're talking about in this initially are state payers, like for Medicaid, correct? I mean, when we talk about the contracts not being in place and
Correct.
The patients are covered by Medicaid.
So the Healthcare Authority has not yet determined, I mean, there's no formula for distributing the funds to the
Right, but it would be Medicaid, but I think as we pointed out
Medicaid
before.
have instead.
Right, and then because other payers tend to follow their pattern, we would see it.
Stay tuned.
Yeah.
Right to follow up.
Right.
And all of the metrics that we're talking about are measured in a Medicaid population.
Okay.
So we've talked about federal government and where the state government's at, and now looping back to that those private-public organizations. So the BREE Collaborative was established by the legislature in 2011 to reduce variations in care, improve outcomes, and increase value. We talked about that, and they've been out there doing their thing in the quality world. Puget Sound High Value Network, this is their stated mission. And the Washington Health Alliance is an interesting organization because they began life as the Puget Sound Health Alliance, and they were working with Boeing and Amazon and Microsoft and really representing purchasers with the plans and trying to make inroads into the providers on behalf directly of the purchasers or the employers. So I was at a meeting that's like Tuesday, say, where they were talking about, we asked the rural question, you're the I-5 corridor, what are your plans out in rural Washington? And they said, well, we don't understand rural. We don't, we're about the I-5 corridor, we're about the Puget Sound. Later that week, they announced the name change, and they were all over the state of Washington. So they have a lot of metrics. They equality to the Washington Health Alliance in very large part equals cost. So, but they are out there on behalf of large purchasers, and now they're moving into smaller purchasing groups. But these private, sort of quasi-public organizations have been doing work in an entirely different arena. And what we're seeing is this all comes together as sort of this cross-pollinization. And Kevin pointed out, you move from table to table, the same people are at the table, and we're beginning to see that come to light in the product that they're talking about paying us for. So, what's next? Remember the ACOs we talked about? There's now a rural model that aggregates rural systems from around the country in order to achieve the necessary critical mass in attributed lives. So as we look at becoming a rural ACO, we may be 4 hospitals in Washington, 3 hospitals in Idaho, 2 in Mississippi, and 1 in Wisconsin. And we combine ourselves so that we have the attributed lives that we need in order to participate in this data sharing and learning and in the upside risk of caring for patients this way.
Can I ask you a quick question about that? On what basis do they group you with certain hospitals?
Well, to a large extent, it's up to you. So we're looking at two different options for entering into an ACO. One is through an organization called Caravan. The other is through the Washington Rural Health Collaborative. So we'll go through and say, we like the character of these hospitals. I think they align with us. When you look at hospitals in Mississippi and the Caravan ACO in Washington was in fact a Washington-Mississippi combination. It's because you have life services, and frankly, it just pulls together the right attributed lives. So, so the vision of an ACO is that you're going to influence referral patterns and utilization among the entire group, the entire body of attributed lives. Clearly, as we move into this model, you're not going to do that. We're going to do here in Ellensburg what we can to influence health and influence cost. We can't influence what's going on in Wisconsin and Mississippi. So, but it does smooth the variation. Again, the larger the pool you have, hopefully the less variation you'll have. The IT systems have truly caught up, and CMS is much more timely. They're about a quarter behind in distributing their beneficiary cost. The IT system most of these ACOs are using is called Lightbeam, and that's the product that we're looking at for both of these things. If we decided to join a Medicare ACO, we have at least two options. I just mentioned those. The decision, the application, and the decision to go into this is in June. We need to have the application in, and that is for January 1, 2019 date. And Libby is spearheading a group of folks that is looking at those options for us. So ACOs have kind of become real, and I think we looked at an ACO here at KDH in 2015 and decided we weren't ready for it. I think that was the way a lot of mid-sized and rural hospitals responded to this. We wanted other people to see if they could get it right. It's getting some traction now, and hospitals are seeing a return on this. So there are upfront costs, not much upfront in terms of an application fee, but as we look at what is our probable attributed lives here, it's about $200,000 a year for us to participate in an ACO, and it does mean reaching into the primary care clinics and dramatically changing the way that we provide care there in order to meet the 34 quality measures that all of the ACOs have to respond to.
Who determines that set of 34 quality measures, and is it tied to the ACH that Kevin was talking about at all?
CMS determines what the quality measures are. In an ACO like the one we're talking about, I think you have to have 628 attributed lives reported in each one of the 34 measures, but you can do a lot of scrubbing among that 628 before you submit them to CMS. So CMS has determined what they are. And in this particular model, it does not connect to the ACHs. You'll see in a minute that it is kind of wrapping back to the Healthcare Authority in another way, though. So the ACO was a federal model, but the Healthcare Authority has decided that they like the idea. So we're bringing it back around to this cross-pollinization I was talking about. They're convening groups to discuss what they're called the multi-payer plan. So one of the things I mentioned that a problem with the ACOs is it sets you up to deliver care one way for the Medicare population, and your incentives are different for the other populations. This multi-payer model, or MPM, is a Medicare-like ACO that includes those 25 to 30% state purchased enrollees, the Medicare component, and they are also inviting private insurers into the mix as well. So this is them going, hey, we like that idea. It limits the risk, it shifts some of the risk, and now all of a sudden you're beyond the 30% that's Medicare, and you're into some real risk in terms of how revenue is going to flow. Healthcare Authority does seem committed to this. They talk about it at every meeting. People are not jumping on enthusiastically, so there's not a real timeline out there. But it comes up at every meeting, and they're not asking if, they're asking how and when. So I think this NPM is getting traction with the Healthcare Authority. Bundled payment. So the Healthcare Authority has teamed up, that's that total need that you get $50,000 for, and you're responsible for everything. So the healthcare authorities teamed up with the Breed Collaborative, who heretofore was out there doing this independent quality work, to recommend that the state purchase certain care only through what they are calling centers of excellence. And I have to admit, this is the slide where I sound a little bit bitter, okay? So the Healthcare Authority BRIE equates quantity with quality. Community providers may not be able to provide some of the services to that 25 to 30% that the Healthcare Authority purchases for. And this is where they really take on that first mover role. So they're interested in setting up centers of excellence, and they've divided care into 4 different components. One is preventative, diagnostic, procedural, and restorative. So hospitals like KVH are welcome to provide preventative, diagnostic, and restorative care. The money is in procedural care. And our friends in the systems and in the urban centers are at the table explaining to the Healthcare Authority and to the Breed Collaborative how important it is that these procedures be delivered at these centers of excellence. So as the Healthcare Authority is talking about rolling this out, and again, this is part of the same conversation that they're having the multi-payer dialogue in, we are welcome to provide 3 components. They will give the centers of excellence extra points, whatever that means, for contracting with the community hospital to provide 1, 2, and 4, while the center of excellence provides 3. So this is, and you know, from my career in healthcare, procedural medicine is where your hospital leans in order to provide emergency medicine and to deliver babies and all those things that you lose money at. The other thing, so besides financial viability, there is reduced access. They acknowledge that folks in rural communities who have to travel for these services will frequently not get them. They just will not go, or they won't get the kind of follow-up care that they need. Our trauma service is at risk in this case because if we rely on the same orthopedic surgeon who supports his practice with totals in order to respond to our emergency department when there's an MBA. And if you can't support the orthopedic program by doing elective procedures or certain elective procedures in your organization, you're really going to struggle to figure out how you can provide orthopedics to your trauma service. So it becomes a cycle. And the other thing is when you have moved, and remember their goal is not just to move their 30%, they want to be the first movers. They want to improve health for the entire state. And you can't have a dynamic orthopedic program 5 years from now if there's not enough volume there, and it becomes a self-fulfilling prophecy. It becomes more and more difficult to recruit and retain the workforce that you need to support those programs when they're all centered in urban areas. Next. More of what's next. Intergovernmental transfers, or IGTs. So going back to the 1115 waiver, those waivers will be funded with IGTs. So the state's portion is the $1.5 billion, and we are the state's starting to move that money. It will be transferred by private providers to the federal government. The federal government sits on it for a couple of days, and then they match the $1.5 billion and send back $3 billion. So providers in Washington have to pony up $1.5 billion for about 48 hours. They didn't come knocking on KVH's door for $1.5 billion. So the University of Washington will be putting up 80% of the outgoing transfer. Evergreen Public Hospital District will be putting up the other 20%. When it comes back into the state, all of the public hospital districts have to benefit by that transfer. That's part of the statute that requires it. So next. So what that means to us. We are committed to staying involved with the ACH. We have Dr. Martin and we have Mandy there at every meeting to make sure these conversations don't go sideways. And more than once, we've been at the, if you just let the Tri-Cities and Yakima do this, we got it. You don't need it, So, and we have the rural folks there to say, wait a minute, that's not the way this should work. We're committed to creating a structure here in rural Kittitas County through the Kittitas County Health Network. So again, that's where we have the university, we have the fire department all coming together at a table We created a 501c3 that can accept the grants, that can contract with the ACH, because we don't think it's efficient for the ACH to contract with every clinic in town, with the fire department, with the A-team, with the hospital. What we tried to do was put together a group, 501c3, that could say, all the people you want to contract with are at our table, contract with us and we'll handle the obligation from there. They've been really reluctant to do that. We had some sort of seed grant money that they gave to us, but for some reason they really are enamored with the idea of contracting individually with every single provider. But we're going to continue to hammer at that, and until I get fired, I'm the chair of the Kittitas County Health Network, so we're meeting on a monthly basis to try to keep this thing moving. We've assembled a group to look at Caravan and the Washington Rural Health ACO, and we are probably going to be in this deal in 2019. So again, we're going to look at the cost benefits. But we will participate in the IGT, and there's 3 because it's 16, 17, and 18. So we'll get probably about $26,000 per transfer this year. So Libby is working with the multi-payer model, and we have quality staff, Julie Hershey, who's attending the BREE collaborative meetings again, to say, wait a minute, there is no data out there that says a provider has to do 150 totals to have good quality. They are leading with a business model, not a quality model. So we really feel it's important. Again, a lot of these things we've been talking about for years, I think, are sort of coming together. They are real, but in many ways they're still really half-baked. And we spend a lot of our time scrambling to make sure we're at every meeting so that we don't miss something, or that rural's not left out, or it doesn't go sideways on us, or something's overlooked. So we also strongly believe that when you look at the Greater Columbia, Kittitas County is a sophisticated rural county, and it's a collaborative rural county. And we should be able to pilot and make work a lot of things that the ACH and the state is looking for. So we're really putting ourselves out there to contract for these things, to do the reporting and be in the middle of this, because clearly Garfield, Soap, and some of the smaller counties are really going to struggle to do that, and I think we're well positioned to do it. So that's what keeps us up.
A question on the BREE collaborative. It was 4 components of care. So is this saying, if it goes fully implemented, that you could only do 1, 2, and 4, all those component cares? What do we currently do with procedures? What percentage of like revenues or services here at the hospital come under the rubric of procedural care?
So what they're talking about right now are total joint replacements. So that's knees and hips. And we do, our orthopedic program is very large, and it's significant to our revenue stream. So the way this would work is Swedish ISAQUA would come to us and say, hey, we want to partner everybody in Kittitas County. You do the screening for, you do the pre-op for, and we'll come pick them up in a bus and take them down. They'll spend 2 days at our place, and we'll ship them back to Kittitas County, and you'll have all the PT and restorative care that goes from there. And then they've received a bundled payment, and we negotiate for 1, 2, and 4, how much we're going to be paid. So, but the actual procedure, the replacement of the knee or the hip, would be done in ISAQUA. And right now we are doing those.
So that's pretty significant.
It would be significant. So, and it would mean, if it goes that direction, and there's a lot of pressure for it to go that direction, we would be sitting back and retooling our orthopedics program. It wouldn't be the end of it, but it would certainly change the nature of how we negotiate with these partners about what we do keep here.
And the prospects of being a center of excellence is pretty low. If not zero.
Yeah, it really, that concept is getting, it's hundreds and hundreds and hundreds of procedures. So what we're trying to do is really say, put a value on that care that will not be delivered. People who will just say, well, I'll just wait, or I can't ask my wife to drive over, and that's who falls through the cracks. And to really carve out that place for community hospitals like KDH to continue to deliver the care. And if you'll recall, we're in a particularly vulnerable place because as we looked at the data at the border tree about the critical access in rural hospitals that were doing surgeries and deliveries, I think there's like 6 of us. And we were trying to hold the ground for all of rural Washington with the 6 community hospitals that provide these kinds of services.
How much in the decision-making process does the patient have? I mean, can the patient say, I don't want to go to Issaquah, I want to come here?
Not very much.
Unless you want to pay for it yourself.
Yeah, that becomes where their procedures, and it wouldn't be all procedures. They're going to pick, columns of procedures like total joint replacement and things like that, and they would go in buckets like that. But again, it changes the entire nature of what a healthcare delivery system like KDH does.
Let me make a comment on this concept of numbers equals quality. Scientific studies have been done on that, for instance, in New York City, regarding heart surgery, for instance. And what they find is that the centers with the big numbers and the super results very much cherry pick the best patients and refuse to do high-risk patients.
Well, and as Kevin pointed out, so they're going to identify 3 or 4 centers of excellence for cardiothoracic surgery and for joint replacements and things like that. And then those 4 centers get to compete on price for the state's business. So, there was a time when cost and quality were on 2 different axes, and they are now all components of solving for X. So they're all part of the same equation now, and I don't mean to sound cynical about that because I think, I don't think people perceive that they're throwing quality in the bus here, but they're leading with cost. And it is very much an urban-centric discussion. And I like to say that people around the table have long driveways and evergreens in their front yard, so they think they're rural, and they get it. And it's not scalable, it's not the same. And so again, the hard work is being at every single meeting and just, pounding the table for our communities. And being really careful not to defend the structure of what we currently do, but to defend access for our communities. And I think that's a much more defensible position for a hospital like ours than, you just can't take our review program away. So.
Well, and the point Julie made the other day, if you define cost as a component of quality, then no care is quality care. If you aren't spending the money to deliver, so failures of access actually become high quality.
So,
what you incentivize.
I know. So anyway, a lot of stuff coming together. I think we've given it to you in pieces, but just in the last 6 months, it's felt like all this is gelling. So yeah.
I'm just amazed how fast this is moving and the kind of dollars you're talking about. When 6 months ago, we didn't know if Affordable Care was going to be around.
Right. You're absolutely right. And I will tell you, the 1115 waiver, they're talking about it for the first time in 3 years. And what's going on in Washington has really got a lot of people in our Washington and Olympia really, really concerned about that. So, but it's still moving ahead at this point. So.
Additional questions?
So I can't wrap my head around the idea that a patient would be mandated to go and have surgery a fourth of the way across the state or a third of the way across the state.
You don't have to. The payer just can decide they're not going to pay for it.
Well,
Payer can what?
Say, you can have that surgery, but we will only pay for it in these facilities.
So
we could still do joint replacements, but they're not going to contract with us to pay us.
So how is this good? Why do we even show enthusiasm for this?
Well, I don't think we do.
Well,
I'm not getting that from you. I'm hearing relative affirmation of all of this, and maybe I'm missing.
Well, I think from my perspective, Rural is an afterthought. This is all being driven by the I-5 corridor, by Seattle, to the lesser extent by Spokane. It is an opportunity for them to pick up market share. It's an opportunity, and again, these don't have to be evil organizations, and they will provide the best care that they can, but they don't understand what the impact is to people outside of the Seattle area. And if it's the direction it's going to go, we're not going to be able to influence that. And when you have, and I don't want to sound like it's a done deal, because I think they are still listening, but Breed Collaborative carries a lot of weight. Healthcare authorities purchasing 30% of the healthcare in the state. These are powerful organizations with the two messages, quality and cost, that they need, and they have the market. So leading through this change, redefining within the constraints what we're going to look like and how we're going to serve our community, and frankly just stay really self-righteous about our citizens' right to high-quality care is going to be the new job. Kevin told me I could only have 3 slides, so I've been over budget on slides.
Okay, any additional questions?
So the bottom line is that this is happening even though we really don't want it to. The best we can do is to continue to be part of the conversation and to raise consciousness about the opinions of the communities.
And it sounds like there's resistance on some things, especially on the Centers of Excellence idea, the numbers that they're trying to give. So it's not a done deal. Okay, thank you, Julie. All right, so now's the time for public comment announcements. If anybody has comments to make, please state your name and your address and try to keep it to a few minutes. Is there anybody here who would like to make a public comment? Okay, thank you. All right, moving on to reports and dashboards. We'll start with Mandy Olson for quality.
Anyone has any questions? I want to add just that we did have a call recently. I think in my report it talks about going to Press Ganey for our patient satisfaction surveys. So we did recently have an onboarding call with them this week. And that will, plan is July 1st, they'll start receiving patient files from us, and Press Ganey will be calling our patients.
Any questions about dashboard, about the report? I will mention one thing, just passing, that at the last QI Council meeting, we did review a patient and family engagement plan. Roy and I were in attendance, and this is a way to get more patients and community members involved in some of the committees at the hospital, to get more input in running the hospital and some of the decisions we have to make. QI Council is very supportive of the plan that was put together, and the idea is to start by getting patients and other community members involved, as members in a couple of committees, and then perhaps, after we see how that looks, eventually to perhaps establish, a patient and family engagement committee. Is that what they would do? But that would be down the line as a possibility. Anyway, at our next meeting, our next board meeting, that plan will be brought forward for everyone to review. As I say, Roy and I were at QI Council, and QI Council as a whole is very supportive of this plan. I think it's a really good direction to go in. But just a heads up that will be coming before the full board. Any questions or anything to add to what I said?
No, it is part of the strategic plan also, and so Eric has also reviewed it as the sponsor of that strategy.
Yep. Any questions or comments for Mandy about her report or the dashboard?
I don't think I put it in the report though, but the dashboard is going to look a little strange for a while because of our transition to Cerner. We're having to build some new reports, and the way we're care still is being reviewed every day, but it's going to be a little challenging to get this dashboard, the data exactly the way we've had it before for a little while. So
Yeah, there was a delay in getting some because, as I understand it, and you can correct me if I'm wrong, you could run a report under one of the systems that was, the legacy system, but the new system was a little hard to figure out how to run the report that would get the same data from the newer, from the people in the new system. And so they have to kind of figure out how to get accurate information using two different systems.
well, and I will say too, previously we had many reports that were custom built in Paragon, and so that obviously isn't going to live in Cerner. We're going to have to rebuild them, and we have people who've been trained and are starting ideas, and working on that. But you also need to validate that data and make sure it's accurate before you start using it and sharing it. And so that will take a little bit of time. There are some things that are much better with Cerner as far as abstracting quality data. The module that Claudia is using is excellent and going to make that chart review much better.
And just so, just to fill this in, when you say validate, I think what you mean is that once they run a report and find out, what the report shows has happened, they actually have to go into the specific patient's records to determine whether that's an accurate accounting of what's going on.
Well, a great example is like a mortality report, right, which shows the number of deaths you've had, which we need to measure that. We need to look at all those cases, and so we generally have low numbers, mortality numbers, so we know how many patients should come up in a report. So you pull a report and you go, is everyone on there? And so far they're not. So yeah, that's part of that validation process. What came out, was it what we expected to see?
Any questions for Andy? Okay, thank you very much. Move on to the CEO report.
So I just have a couple things to add. At your place is the 2017 annual report of the Washington Rural Health Collaborative. You'll see that we are welcome to the collaborative in it. And we're going to be doing a lot of work with them on joint purchasing. Again, they're one of the ACO's proposals that we'll be looking at. But it really is a nice opportunity because the N, as we say, in rural healthcare is so small sometimes. It's really difficult to put together a body of information or statistics to demonstrate what you're doing. But in 2018, the Washington Rural Health Collaborative, one of their objectives is to aggregate all of our quality data and as much data as they can under the heading of better than bid. So we'll be reporting all of our aggregated rural data under better than bid. So you have that. I wanted to mention that I had intended to attend the Trustee CEO Summit on April 30th, and I will not be able to go to that. So I think somebody is going on the 1st and somebody is going on the 3rd.
I'm going on the 30th, so I
So you're on
can
the
report back to you.
So that's a great event, and I wanted to go with it. I will be gone the 1st through the 10th at to the American Hospital Association and taking some vacation time. Rhonda has gathered, one thing that the Trump administration has really encouraged healthcare providers and associations to do is seek regulatory reform and regulatory relief. And one place we think we might be able to make an argument is in the OASIS reporting system in our home health and hospice service. So it's a tremendously burdensome reporting system, and also the barriers between transitioning from home health to palliative care to hospice can really just lock up the patient's experience. So we'll have an opportunity to talk to the person and CMS about that while we're back there, and Ron to put together that stuff.
Okay.
Do you have a
The, just looking at the one source kind of here, the Yakima Valley radiology, it said by the board meeting, we anticipate that billing issues are going to be better.
Well, I thought I did until about 4:30 this afternoon, so. It's a, I'd like to say it's a 2-step forward, 1 step back. It's more like a 1 step forward, 1 step back. I believe they have everything they need to bill March and April, was what I was told. And then we knew we were having some issues with February. I was exchanging emails literally at 4:45 because they're saying now they're back to not being able to gather and bill for those services. So at the very least, it's a very iterative process. So we send the file, it bumps into a problem, we fix that problem, we send it the next day, it bumps into the next problem. Right? So I'm asking for interface specs and for a complete problem list that we can address. So we'll see where it goes. Again, we thought it was 6, and we heard very late this afternoon that it wasn't. So I think 2 of the 3 months. Unfortunately, it's the latest stuff that they're still having issues. Latest being the latest in the billing cycle. So they're saying if they fall outside that 90-day window, they won't be able to file as well. So. Yeah.
I'm liking the term here for the pipeline regarding the claims movement in the process.
Yeah.
There's a picture. And then Leona and I on the board too, we suggested that I would say that we're going to become syringes or or something, and follow it all the way through the material cycle from where it begins until the end user, which I think will be really learning. So we need to get that schedule. We're going to have to pick our instrument, and we're working with Frankie to figure out. I know that this is just a crazy time of schedules and such, but
And I think Roy's also, is that right, Roy? This is something that you were interested in.
Yeah, I did come up with the coffee with the commission.
to go through the cycle.
Yeah.
And can you refresh me, is that there can be more than 2 as long as we're not connecting with this, is that right? Or
Yeah, no, I believe that's perfectly appropriate. It's just a tour of the facilities.
So you're setting this up.
So the one there,
Yes, you just let me know when you're ready.
Would you mind keeping Roy in the loop?
I will do it.
Thank you.
sounds great.
And then I would like to call your attention to the 17A, the concert with Phil McLaughlin. I'm working with Dr. Berger, we're putting it together. His story is really, really amazing. He is a major guitarist, and he played with Chet Atkins and many other noted guitarists in a certain style. I don't know very much about music, so I can't comment on the style, but he has been internationally recognized in recordings. You can see him on YouTube if you want to. But I think it's about 10 years ago, he developed an incurable brain disorder that crippled his playing talent. And suddenly he went from being an international musical star to unable to exercise his art. So he taught himself to play with his other hand. And it's very sophisticated use of digital manipulations. And now he plays with equal grace and beauty with his other hand. So he's inspiring for coming to a point where he could recreate his craft against almost insurmountable odds. I really appreciate Julie's willingness to help become a sponsor for this event, and I encourage people to try to attend the concert on May 4th, Friday night.
Okay. Thank you. Anything else on her report? Did you want to say a few words about the first quarter report on the business plan?
Well, I think that we talked about this as we were sort of going through the presentation of the board. We don't want to read what we've written to you and everything, but the idea is, this is the commitment we made in reporting deliverables on the strategic plans that needs to work for you. We want to make sure that each of the board sponsors has had an opportunity to participate, understands, and feels that we're really, on target with what the board had laid out as the strategic and tactical objectives for the organization. So I guess the question to you who have participated in preparing this, is it keeping you connected? Is it the direction that the board sponsors want to go in these areas? Is it useful?
I could speak to that, maybe just it was last week. And she went over, can you remind me the name of the
Patient family engagement.
engagement? I'm going to call it the Electric Council's telling me this. Oh, thank you. And I think incredible benefit from this program, this initiative that Mandy went over with me. Some of the bullet points of what we hope to achieve out of this, I think, will really show a commitment to the community, show our commitment to the community to, instead of just guessing at what community needs are, to involve them and extract that information directly from them, and make sure that we are being good partners with patients and families. So I don't want to steal a whole bunch of Mandy's thunder on that, but I was very impressed with the meeting, and I think that that's really hitting the mark there for the community engagement.
Yeah, and that's like, one little box on page 3 of the 33. Yeah.
Is there anybody? Yeah, go ahead.
Well, as you go, so things that are in green we consider done. So if you have an argument with that, you think there's more work to do, please let us know. One of the things we found as we sort of highlighted things that are in progress is that we're really struggling kind of with the who's on first, what comes first. So the timing is a little different than we thought it would be. And there's a lot of overlap in the initiatives as well. So, Carrie Youngblood and Mandy would be reporting out essentially the same information. So I think that's good, and that it means that our strategies are sort of 3D. But so we are learning how to report this in a useful way, and it is for you. So let us know.
Any questions or comments on this?
I have one question. Which component of the plan are you going to avoid associated?
I don't know if you should.
I was going to suggest that you join me in financial sustainability.
Sure, that would be consistent with the finance committee.
You have so much knowledge and economic good sense, so I know you will.
Really feels like that because no one ever wants to come.
Nobody ever wants to come. And by the way, on page 36, you did pass the budget, so that should be green. Okay.
Yeah, I assume the rest of the board is okay with having Roy for
For sure.
financial sustainability. Okay, that's good. Yeah, so the board sponsors will be Leanna and Roy. Yeah, so that'd be please just keep it. Any additional questions or comments regarding the report?
This is a really useful format.
Yeah, and I've really benefited from the meetings to discuss this, just like Erica has. So we appreciate that. Thank you.
And how well is it being, I guess, embraced by the workforce? When you look at the strategic plan, it's certainly important for us to be updated on that, but our department directors intimately involved in the implementation of the plan, and it's sort of working its way through the system.
I think the department directors are involved in
all of it, yeah.
particular strategies and tactics, right? So.
And we really are trying to be really disciplined about bringing things back to strategy and highlight that. Strategy is not a project.
That's fantastic, yeah.
That being said, we had a plan to roll out the new mission values in first quarter. and decided to really pull that back to the second quarter because of sooner. So I have my open forums, all staffs, this month, or whenever Michelle tells me to do that. And that will be the focus of this. But we are sincerely trying to guide people's discussions back to the tactics and back to the strategies.
I also wanted to call out, and I expect this is true for all of the committees and whatnot, that with community engagement and notice that there's a definite pacing. I know that there was a big concern for, years not too distant ago, that everything was happening all at once, and we had to make it all happen now, and there was no sense of pacing. A lot of people were feeling overwhelmed, and this brings me great peace to see populated across the calendar in manageable chunks, and so kudos to all who are involved in populating that calendar.
So I do get to tell a story. When the timeline first went up, it's a 3-year timeline divided by quarter. First and second quarter of 2018 was just a massive stinking. And I kept sending them back up there and going, you guys, no, you need to go move those. And it took a Gary Barr and Mandy were particularly bad about that. So we finally got them to go, no, we're not going to change the world by April 30th. But it is a real, because people are really enthusiastic about this work. And they want to get in and they want to do it. But you have a day job too. So
the CEO is telling you not to work as hard. Right? Remember that during
it was pretty funny. I have the pictures to prove it. I have the pictures of the timeline.
I would argue that you are changing the world just one step at a time.
Any additional comments or questions regarding the report on the progress of the business plan? Thank you for this detailed report. Okay, next we have Chief of Staff, Dr. O'Brien.
Okay, yes, I see there was 2 different lists put out, one on the 18th of April and one on the 20th. I don't know which one you have.
In their supplemental agenda, is their latest one,
Now,
which is the went doctor.
Maybe,
Okay.
Bernadette Wards, that was
Right,
the only one.
it was removed from consideration.
So she is not.
Right, she was at Local 10, working at Virginia Mason, now she's on.
Okay, right, that makes things easier.
Yeah, take that one off.
Okay.
There's also additional information in your printed copy of who they are. It's a little bit confusing the way it's done. Next time I'll try to help in the way it's set up. It's good in that it has actually written information on who these people are, so I don't have to just orally transmit it. First of all, under specialty, you see there's 4 of them that say direct. Well, that should say direct radiology, obviously. There, KVH Wound, Mary Newens is KVH Wound Clinic, where she'll be working. And of course, the resident is a family practice resident. The others under specialty are explanatory. It's a little, when you look under the left-hand list, or column, I should say, of practitioner, it gets a little hard to read because you have radiology inserted and dermatology inserted between names. Anyway, long story short, I think you can figure it out.
Yeah.
And the Medical Executive Committee is recommending that you approve these applications, appointments, and reappointments.
Has everybody had a chance to review these?
I have to say that for personal reasons, I didn't get them all read. Should I recuse myself from the vote?
Yeah, I think that's probably best if you have. Has everybody else reviewed all of it? Okay.
I'll make a motion that we approve the NEC's recommendation.
Okay. Motion from Bob Dish. Second? Second. Okay. Roy seconds. Any further discussion? Okay. All those in favor of approving the list of practitioners for credentials. Please say aye. Aye. And one abstention.
No, recusal means that it's unanimous because there are only 4 eligible voting.
Okay.
Okay, and I do want to add too that we are going to update some of our processing of these. First of all, to have them available to you earlier. We'll be having our medical executive earlier in the month, so enough time to do the interviews ourselves. And second is we will have a system of the actual, all the members of the committee signing off on them as well before they're being voted on.
Well, Dr. O'Brien, we really appreciate you looking into that process. So thank you for it.
No, Dr. Silver and I spent hundreds of hours designing all the way these things are handled and requirements, etc., of all different specialties. And that was several years ago. And since then, it's sort of been the secretary and myself that have been doing it all. So
maybe it'll take a little weight off your shoulders.
that's what I was going to say. I could retire just a little bit more.
Good to hear. Anyway, we appreciate your work on that. Thank you.
Okay.
Next, Chief Medical Officer, Dr. Martin.
I will comment that before Dr. O'Brien had that weight on his shoulders, he was 6'3". Day 4, week 4.
You have to quit counting.
It's kind of like having a newborn. I was telling Mitch Engel this earlier today. There's that stage when you have your first child at home and everything is still new and different and you have absolutely no recollection of what your life was like 2 months ago. And that's kind of where I'm at right now. There have been some changes to this report since I wrote it. We originally anticipated having Mitch present our recruitment plan to the board this evening because of the presentation on alternative payment models and the size of the agenda. We pushed that back to next month.
Okay.
We did have a GNP start this month, Marquita Washington. Since this report was put together, we signed a contract with another GNP so that I think we're pretty fully staffed there for the time being. We're actually looking at ways to expand that program and provide greater service and greater access. Dr. Chima stepped in and was helping out. She was originally going to be doing mostly call coverage with Dr. Longa's injury. She has stepped in and helped us tremendously there. We're continuing work on pediatrics and building succession plans in workplace health. That's going to be a larger item on next month's report.
Probably talk about that in the session.
Do we know when the recovery track for Dr. Longo, how soon she will be back?
She's out of her boot and out of the sling, so she's doing physical therapy on her arm. So
I didn't even know what she was.
Oh yeah, she's back.
Oh my
Yeah,
goodness.
yeah, she was back. Two separate
cool.
injuries, but she's never left, and is seeing full patients. Her schedule was getting 21 patients today. She hasn't slowed down at all.
Oh my goodness.
So she can't deliver patients.
She cannot deliver
She can't
patients,
catch.
right? But that's not stopping her with the others.
Because you're catching it.
Yeah, she's
It really
very
is. Okay, I thought she had to take him.
She may be able to month, however. Mandy Weed is working on 13 initial appointments, 15 reappointments, 2 residents and a student, and actually we just voted on the bulk of that. Wound Care Clinic. We had initially planned to have a meeting with our consultant and Cerner to look at what the IT needs were to support that line. That meeting was scheduled for April 20th. Our consultant is currently in Europe on a family emergency, and that meeting has been pushed back till sometime in May. Dr. Meyer has been seeing patients a day a week, and we hope to have continued presence at Student Health through the end of the quarter.
I just mentioned that I read this several times and puzzled over this, and only just now when I sat down to reread it, I was like, I didn't know his
I get it.
No, I get it.
Yeah, all right. So I had a question about Dr. Meyer and what exactly he's doing there.
There we go.
Is he specializing in something in particular?
He has been serving as an interim medical director and trying to help with the access problem. Currently, Student Health is booking new patients in October. And we were hoping to look at their processes and see if we could lend them some expertise. I would like to defer the rest of that conversation to executive session.
Yeah, we can do that.
I think, however, this is our third run at helping with the service up there. So like 2 or 3 years ago, I think we sat down and had a plan to coordinate at least the physical medicine piece up there and time before that. So it's one more example to see what we can do.
Okay. Yeah, we can discuss that later. Thank you. Go ahead.
And then pediatric call for unassigned pediatric patients. Again, this is the void left by Dr. Waltner. We're continuing to work both with our employed physicians and community physicians right now. A number of FME docs are taking turns in the unassigned peds call rotation. I had my first at bat last night, and nothing crossed the strike zone, so that's all.
You didn't get called?
Not on that, no. I was on call for everything else. In terms of CMO activities, writing this in the second week of the month seemed a little premature. At this point, I'll say that it's starting to feel less like a fire hose and more like a downpour. But I'm excited going forward, and I probably shouldn't say this, but I'm having more fun than human beings ought to be.
Wow. Yeah.
You have to be defining the position.
I think it has to do with hiring a masochist.
Maybe that's it. Any questions from the Chief Medical Officer's report? Question? All right. Thank you, Dr. Moore. All right, moving on. CFO, Libby.
Okay. First of all, I want to thank you for your patience in getting the report again this month. I'd like to say that you'll have the report with the packet next month, but I can't promise that because we do need to make sure that we take the time to make sure that the information makes sense. I liked what Mandy said. I want to repeat it. You see what came out, and then was it what you expected to see? And I think that that really applies in the financial area as well. One of the things we talked about in the finance committee was, we have all these charges that we had mapped one way, and with the new system, when we see what comes out, and we see no emergency room physician charges being mapped to that general ledger, we know there's something we should look at. So that's why we're taking the time to make sure this all makes sense before we share it with you. So I know you've only had this report for a short amount of time. Have you had an opportunity to read it? Do you want me to go through it bullet point by bullet point, or can I just add some additional information at this point?
I mean, I've had time, but I don't know if, is there anybody who'd like a brief summary of the report?
Do we know why temporary labor was up?
I don't know exactly. We had that question about whether or not it related to Cerner, but I don't know. It was mostly in the units. I don't think it was related to backfill for Cerner because a lot of that training was taking place, before we went live. But we can certainly find out. It happens every now and then when staff is on vacations or ill. We had a lot of people ill though, didn't we, in the month of March? I seem to recall a lot of people were ill. But we can find out.
What are you asking about?
Right above 2 bullet points above the one source heading.
It's the operating expenses exceeded budget, and I noted that temporary labor exceeded budget in several departments, and I pointed out med-surg, family birthing, and emergency. We now, in our morning huddle, we have a call out of areas, that are short-staffed, etc. And I just recall there being a lot of mention of illness. Yeah, so I suspect that's,
Particularly in the clinics.
yeah, yeah.
And so is this,
No, sorry.
No, go ahead.
is this, historically though, is this considerably more, or is it kind of in line with the ebbs and flows?
It's that we've made an effort over the last couple of years to try to reduce the amount of temporary labor, and so our budget, we budgeted at a lower level of temporary labor. So the fact that we have this is really talking about a budget variance, so we have more than we anticipated in the budget.
So if this went on and developed a trend,
Then we would want to look at it during budget, but we also want to address why is this happening.
So it seems like people have a sense of what's in the report, but you said you had a couple of things that you wanted to
Well, I
highlight.
do. I left at your place the same little report that we had last time, the revenue cycle process flow. I won't go through that, but I did want to, I won't go through the first page, but the cash recovery plan, we have had a few changes to that based on, the experience we've had in the month of March. And a couple of dates have changed. So the data load completed, item 1, capturing patient legacy data in Cerner, made a lot of progress in that area. And now the data load, we have the goal of having the data load completed to support full clinic schedules by April 30th. And my understanding, the last report I heard, we have the data load in there to support scheduled visits through August, I believe. So we're doing a good job on that. We still have to work on when there's a drop-in schedule or something, or someone shows up that wasn't scheduled. We have to deal with that, correct?
Right.
Yeah. Okay. And then the second item, charging for services. And this is where, this is the more real-time bedside charging. One of the areas that we discussed at the Finance Committee, and Julie had asked me to follow up with Morgan regarding the scanning for supplies. And that's still a little bit hit or miss, but working on that. Another thing is the incorrect, incomplete mapping of charges, not consistently using new processes. We had anticipated previously that we would have that fixed, I think, sooner. But now we're saying that this will be 90% fixed by May 15th, and we'll see the result coming through cash by June 15th. Then the last two items, the coding encounters and the claims processing, I think we've moved that out either half a month or a month. We're assuming 80% by May 31st for coding encounters and 80% by May 31st on claims processing.
So the coding encounters,
Yes.
the bottleneck is the way that's solved is to send these, I don't even know, it's not a chart anymore, this a P chart then I guess back to, for the data service or the procedure back to the provider?
In some cases, yes.
For
Some of
clarification?
Yeah, in some cases, yes, but some of them we're still finding that certain codes weren't set up with Cerner, so we have to actually go back and have some.
So there was no way, there was no route to success out of the gate in this situation?
And certainly not everything, but as we go forward, we're finding a few things there, yes. So
But once those are, sorry, go ahead.
Oh, no, go ahead.
I was going to say, once those, like the coding, once those are fixed, then we anticipate that would completely solve that particular issue.
We think so. We do recognize, and we've talked with Carrie about this, at least for follow-up with clinic providers, we do need to look at some new processes, and because we need to push some of that documentation, make sure that it's happening at time of service so that we don't have to do the follow-up. So we're learning that, and we'll be working through those processes. But you're right, we shouldn't have that kind of bottleneck in the future once we've worked through most of this. Does that make sense? Mm-hmm. Okay, great. So then we've updated the graph to based on actual collections that we received in March, and then sort of an estimate of what would happen in April. And then we also added the target, which you'll note that in July we think will be above the target, because I think we're actually seeing that the system is more successful at capturing charges than perhaps we were in the past, which is a good thing. But I do want to report, I was just telling Julie right before the meeting, I went back and looked for keeping track of payments that we're receiving on Cerner account. And in February, of course we went live February 12th, we received $6,000, so not very much.
And matched our tax revenue.
I know, it matched our tax revenue. In March, we received about $655,000 of payments. And in April, as of through yesterday, we've received about $2.2 million. So you can see it's starting to flow, and that's a great thing for us.
It's a little rosier than
It
February.
is, it's very rosy, and we're very fortunate. Again, we were fortunate that we had the reserves that we have to kind of get through the period where the money wasn't coming in quite as easily.
And will we keep getting this until we're?
I'd like to keep providing that to you, yes.
I like seeing
Yeah,
that.
I'm happy to do that.
Yeah, yes,
So,
please.
yes, happy to do that. So,
Thank you.
we're
We have
also,
the-
oh, go ahead.
No, go ahead.
Oh, I was going to tell you on claims, I'm receiving daily reports on claims that are being processed through the system. And early on, we would see clean claims and error claims, and sadly, the error claims exceeded the clean claims. And what determines if it's an error is there are a whole lot of edits built into these systems that you put the claims through. And those edits then kick out a claim, which means you're required then to look at that claim to figure out what the problem is. It's pretty exciting though, because it's now shifted. We have more clean claims than claims with edits, and to the point where we've been able to turn off certain edits because we know that the claims are being put together properly. So good news there too. We won't be slowing down on that. So,
Where do you expect to be once we're at full speed, everything's finally a well-oiled machine? Where do you expect the kicked out claims, that load to be? 'Cause, I mean, I imagine there's always going to be something.
well, there's always something, yes. I can't answer that question, but I would think it would be a very small proportion. Yeah, it's the edits are built in so that the claims, their criteria built in by payer. So the payers could change things too, and all of a sudden something would be kicked out that previously worked. So that makes sense. Yeah.
Bob, do you have a question?
So, our days cash on hand is
Yes.
down quite a bit.
Yes.
And our AR days are up quite a
Right.
bit, right?
Right.
But that's the hospital only.
Yes.
Is there any idea what the clinics?
The clinic's AR also is up,
Yeah.
which we expected because of the slowdown. So.
If we subtract the AR days and add it to cash, we're still kind of low, but that's just probably because production's low.
Well, and we actually planned on this, because we knew that it would take longer to get the claims processed and get paid for them. So we knew AR days would go up. I would expect to see it up, but it's still up next month, although hopefully it's down a bit.
Yeah.
The days cash on hand, because we aren't processing and getting the cash in, we also expected that to go down.
Mm-hmm.
Now, remember we purchased, and this will be sort of a segue into the debt resolution, but when we purchased the MAC building, we purchased that with cash. So we used a lot of our reserves at that point also. Once assuming you approve the resolution for the debt, that will also go in and that will increase our days cash on hand. So.
And I'd also like to point out a lot of the support for OneSource and the Go Live is not showing up in the income statement because we're allowed to capitalize it, but it's still a cash in utilization.
Right. Right.
I have a question. Do you know what accounts for the significant positive variance over income?
Yes, I do, actually. As we had 3 departments where the charges were not mapped to show up in the right department, and one of them was urgent care. So we ended up doing an analysis to figure out, based on statistics, how many visits there were, and we accrued that revenue. Those accounts are they're clogged up in coding, so the revenue wasn't anywhere. So we accrued that. What we didn't do is we didn't accrue the contractual allowance that went along with urgent care. So the revenue in that line, that net is overstated because we didn't take the contractual piece out. We took the contractual piece out of the whole of the hospital.
Of the corporate account.
Of the corporate account, right, instead of allocating it, which we allocate that typically. So next month that will be corrected.
And it'll be
And
more
it will be more normal. I'm sorry.
It would be great. I'm sorry.
Volumes are.
Volumes are up, yes, yes, so.
Okay, very good. Thank you.
You're welcome.
Any additional questions before we talk about the debt resolution? Okay. Go ahead, Libby. You want to say anything about this?
Well, I just would like to point out, so that you don't have to dig all the way through this, the rate on this is 3.43%. It went up a little bit from when we first talked about it. I think initially it was 3.31, but there have been a lot of changes. The market's bouncing around a little bit, so now it's at 3.43. There is, if you look on page 6 of the debt resolution, which is your page 40M, the project, there is a, under section 2, the last paragraph, it talks about the cost of the project. And the amount that's in the resolution that you have in your book says it's in brackets, $6 million. That should be, and in the final resolution, that is 8.5 million, because the project was the purchase of the MAP building, and that cost 8.5 million. As you recall, we're not refinancing the whole amount. We're refinancing 6 million of it. So that's why the final number in there should be 8.5. And it is in the resolution that you have, that you would be approving and signing. So that's all.
Oh, wait a second, you say it is in the resolution, but isn't this 40M part of that resolution?
Well, it is, but rather than giving you a new page, I was just going to tell you what it was, and the one that, the official copy that Frankie has the 8.5.
So I'm just trying to wrap my mind around the debt that we have.
Yes.
Is there a way to get a big picture, like what bonds we have out? We have this one from 2009 or whatever it's called.
Yes.
I'm sure when this year.
I think it's this year. I thought it was next year, but I think it was correct. I think it's this year.
What other?
We have the 13.5 that we issued in 2017, and then we're issuing this to, or hopefully issuing this to refinance the MAP building. We have a revenue. We have a 2009 revenue bond, and then we also have the UTGO, which is actually funded through a tax levy. And that one, I believe this is the last year for that one.
And the 2017 one was primarily to deal with the Cerner and all that, right?
It was Cerner, and then also additional capital building,
Right.
you know, additional, it paid for Radio Hill, and
Yeah.
then we put in that also funds so that we could be doing the remodeling and getting the buildings that we wanted to use. So I guess what I would say about that is, if we look at that 12.5 or 13.5 and this 6, that was what I think at the time we were looking at building an MOB. It started at 15 million and then escalated from that. I don't think the system piece hasn't changed. Part of what's required as we go through this process is a whole lot of due diligence about what it does to our ratios, and the lender, of course, has covenants that we have to meet that requires a certain amount of days cash on hand, requires debt service coverage of a certain amount. And we are well within those, even with the addition of this new debt. Julie and I, in our conversations, this is going to keep us, this is going to take care of our needs.
And one of the reasons we want to do this, obviously, is to have that cash, but because the money's so cheap. Right?
It's very cheap right now, and we don't know what will happen with that.
Am I correct that the cash that we used to buy the MAC came out of the 13.5?
It did not.
It did not.
We
used our reserves.
We used our reserves for
Okay.
that.
So we still have much of that.
So we still have over $11 million of that debt to use for various projects.
Roy, you had a question?
Well, I was looking at the balance sheet on the long-term debt, 2009 UTGO bonds.
Mm-hmm.
Will that retire at the end of this year?
I believe so. We pay, because we get the tax revenue to pay it, we get that tax revenue this year, and I believe the last payment on that is in December.
I think it's a June one, December one.
It's June 1, December 1, we pay interest twice a year,
Okay.
and the principal at the end of the year.
And then the 2017 revenue bonds, the 13.5,
Yes.
is, remind me again what that covered. That was Radio Hill and
Well,
Center.
it covered, there were a couple pieces. There was a taxable piece of it that covered the first two payments, almost covered the first two payments for Cerner. And then, and that was $1 million. And then we got 12.5 that was tax exempt. That has gone to pay for Radio Hill and 2 additional Cerner payments, 2 additional Cerner capital payments. We haven't used it. We haven't used it because we actually haven't had any big capital expenses, although I think we will soon, and we will have that available.
So when we talk about tax exempt bonds, that means that the interest of the person holding the bond is not taxable, so you get a lower rate. But you also have 3 years or 36 months, is that
Yes,
right?
yes.
Because it's tax exempt, you have to tell them what you're going to spend it on in broad, and you don't have to have an address, but these are the projects that we're going to use that tax exempt money to fund. And the new tax bill, I forget what it's called, passed in December, actually significantly curtails the ability of organizations, not necessarily public, but tax exempt households to issue those tax exempt bonds. So we got to
We did.
So if this resolution is passed, there'll be another item on the balance sheet for long-term debt
Yes,
of
there's
6
a-
million or 8.5 million?
6 million.
Of 6 million.
Yes.
So what's that going to do to cash flow in terms of debt service?
I think it increases, I think the debt service is something like $180,000 for principal. Yes, $180,000 principal payments starting in December of 2018. I think I have a full amortization schedule here showing the interest.
working with the same lender, they were able to smooth the debt service payments.
Right.
So they're pretty level loaded debt service
That's the
payments.
BBVA.
Yes, which another benefit of BBVA is that the 2009 revenue bonds that we have out there have some probably less favorable debt covenants. They require a much more stringent debt service coverage, and they require, I think, 125 or 125 days cash, something like that. And the lender, BBVA, in negotiating this, it's 75 days cash on hand, which is excellent. And also, they have a different threshold for debt service coverage. And we are well within. And I think the thing that's important with this is, we've been building for several years to be in a position, we've been, haven't gone out for debt, and we've been building to be in a position so that we're strong enough to get the financing that we need to position us well. And I think this is part of that strategy. Once we do this, then we'll be fine.
But we did use reserves to purchase the MAC building in the fall.
We did use
So
reserves.
how much did that deplete the reserves?
Well, the building was $8.5 million.
So that's the idea, we're, the 6, then we'll cover 6 of that 8.5.
Yes, exactly.
Okay,
And it's a
okay.
refinance for that. And, yeah.
Okay.
So that's why. I mean, to be honest, we're probably one of the few critical access hospitals that could have popped up $8.5 million to buy a building in cash.
What is the mechanism if we go to 75 days, 74 days, cash in hand?
75.
Yeah. Say
If we dip below.
Go below.
If we dip below that.
That's,
Well, there would, we have to report on that, obviously. I think it would be in default, but again, it's based on year-end, audited financials. They can't ask for it all back, but they would negotiate with us, okay, what's the situation here? Do we need to change the payment schedule?
They would ask for a plan of correction
Yes.
and require us to go out and do a line of credit or something.
Something like that.
But you have no reason to believe that.
I would be very surprised. I'm trying to think, since I've been here, I don't think we've ever been, maybe when
we've not been recommending.
The answer is no.
I do not think that will happen. But you know, that's part of being prepared for these changes that are coming. So that's part of understanding what we need to do. You know, I think it.
Bob, did you have any other questions? Leon?
No.
Erica?
Thank you.
Okay, so the motion would be to adopt this resolution. Resolution 18-03, which will provide for the issuance, sale, and delivery of a $6 million aggregate municipal amount of hospital revenue bond.
I move adoption of the resolution.
Okay, motion from Leona. Any second? Second. Okay, Bob Davis seconds. Any further discussion? Hearing none. All those in favor of resolution number 18-03, please say aye.
Aye.
That's unanimous.
Thank you very much.
Thank you.
It's actually supposed to close on May 2nd.
Okay.
Which is actually refunded.
All right. Next, Finance Committee reports. Leona?
I don't really have anything to add. We had extensive discussion of all of these elements that were in Lee's report, and I don't think there's anything additional.
Okay. Well, thanks, Leona and Lloyd, for representing us on the committee. Next on the...
I do have
Oh, yeah, sure, go ahead.
I have a couple, I think that I'm going to talk with the members of the Finance Committee. We have one member, we briefly discussed this at the meeting, who has not attended regularly for several years, and I think we're going to ask her to step off the committee and replace her, and I have a couple of ideas about who that might be, and I'll talk with the other Finance Committee members on Tuesday.
Just be sure to keep the members of the Finance Committee in the loop. And thank you. All right, operations. All right, Rhonda, you're going to take next
Yes, Vicki is not here tonight. So one thing I would say in her report is they did have a very successful trauma program event. We had 51 trauma nurses on site and another 21 going online. So that was just incredible. A huge amount of work by Cody and Dee Utley and the ED. And I think the state was pretty impressed with the turnout. And it was a wonderful location because they came from the west side and the east side, met in the middle. So just really fabulous work there with that group. For my report, would you mind?
Can I just say something? I had an opportunity to address both of those groups, and it's always impressive to me because it's one thing to be a trauma nurse in our review where you have 100 subspecialists and all that you need. The confidence and the competence required to fill that role in a rural hospital where the passes are all closed and you are it is amazing. And talking to that group and saying you really need to reach out and talk to these rural nurses and the rural trauma providers because it is an incredible job that they do. And I truly believe it's tougher to do it here than it is to do, at the level 1 trauma center in the state. And they do an amazing job.
I'd also like to comment on this. I saw this pop up as a Facebook event. Some of my nurse friends here said they were going to the April 20th Washington State Emergency Nurses Association meeting. And I was thrilled to see that my own evidence-based practice instructor, Carla Brim, was one of the speakers for that. So I wish that I could have been there to see her, but I was in school. So it's pretty cool.
Yeah, thank you.
Thank you. And go ahead, Rhonda, with your...
Okay. Do you mind if we look at the physical therapy expansion portion first?
Sure.
This document in front of you. And it's been probably 8 or 9 months since Julie asked me to start looking around for another location for physical therapy. As you recall, they are currently in Family Medicine Cleolum. And we have a therapy room that's about the third of the size of this room. So that really greatly limits the amount of equipment that we can put in there and the type of therapy that we can give to our patients. And our therapist actually has to ambulate patients out in the clinic hallway whenever he's doing the therapy. For support staff, we've remodeled a closet, and that's where the support staff resides. So they really do need to have another location.
And I think I went in pretty much every vacant building in the Cleveland area last summer looking at space. And as you can imagine, they all need a lot of renovation, which would be really costly for us as an organization. So I was pretty happy whenever we had an independent therapy practice approach me. I think word got out that I was scouting around looking at different areas. And so he actually approached me and asked if KVH might be interested in purchasing his practice. So he does already have an established building that's functioning as a therapy office. He has a very capable and competent staff working for him. And there are renovations that would be required. I believe the DOH would require about $140,000, and then we would purchase equipment for around $88,000 as well. So what you have in front of you is the latest efforts of Lisa and Jason Adler to kind of give you an estimate of what it would look like if we were to purchase this practice and move our therapy into this location and conjoin the two. So on the left-hand side, in the blue box, it says KVH current state. That is our current practice and what it's forecast to do for 2018. The pro forma in the middle is the independent practice and what they are forecasted to perform over the next 3 years. And then on the far right is the combined practice between KVH and the independent practice. I want to just kind of call to your attention a couple of things. If you look at the top line where it says physical therapy visits, you can see that they've added the KVH current pro forma with the performance of the independent practice to come up with 5,676 visits. That's a very conservative estimate. It's a low estimate. Our current therapist is not at 100% capacity. He's around 60 to 70% capacity at this point. Part of it is staffing limitations. He does have room to grow, and he would be very able to grow if we moved him. So I think that that's incredibly low. In order to break even in this pro forma, we would need another 204 visits a year, or just 4 more visits a week. And if we actually increased our numbers up to the 1,911 that you see there for the pro forma of the independent practice, we would be making, according to Jason, he told me today, our profit would be $50,000. So much more reasonable, and I think very easy to achieve.
Do you think there's that much demand up there?
Yes, I do. I know from Swedish, when they closed their number 2 referral out was for physical therapy, and I believe they had 81 visits that came just out of that practice.
Yeah, I mean so there's like a 1,500 visit addition without taking over. I mean, obviously we'd have more therapists there.
Right.
There's enough demand.
Yes, I do believe there's enough demand for that. Other things that are added in, you can see the depreciation, and that is for the building expense and for the equipment expense, which would not be there after 5 years. We amortize that for 5 years. In other indirect expense, we now have $55,000, and we have included costs there for housekeeping, for billing, and all those other departments who would be helping to manage and keep this department afloat. We don't currently outsource that, and you can see over in our current state for the physical therapy department, there isn't any cost associated with that. We just consider that part of doing the business at KVH. But in developing the pro forma, they were trying to be very realistic and looking at what other burden there might be on hospital services. Not that we would add staff in those departments, but just recognizing that there is additional work being placed.
Yeah, so those costs are allocated, they're not incremental. That's just showing the existing burden to shift it over.
Right. And then under net operating income for year 2 and year 3, that is because of a retention bonus that we would be paying the director, having him stay on. That would be part of the pricing structure for purchasing this practice. Of course, that would be gone also after the end of that contract. And you can see that in year 2 and year 3, there's a loss, an operating loss because of that retention bonus. it sounds like Bob and Erica had a really good conversation with Hospital District 2. And from my understanding, they don't have any objection to us providing therapy services within their district, and they're willing for us to do that. I think their biggest questions have been, should they invest money in a building that they don't own, and seeing that that might be helping the owner. And a piece of that is recognizing that the work that has to be done is for us to be able to provide those services. The Department of Health actually is having us sort of tear up portions of his beautiful building in order to meet the requirements of the state. And an example of that is in the break room. He currently has a break room with a washer and dryer in it. We would have to rip that out, put in a janitor's sink, and then move a break room upstairs just to fulfill the requirements of the Department of Health. So it's not a beautification or an enhancement of his building in any way. The other piece I think I heard from Hospital District 2 is that they felt like if they did invest money, that they would want to see some sort of return on their investment eventually. How would they earn that money back? How would it be profitable for them? Is that correct?
That's right.
Well, the return is increased access to physical therapy. I mean, isn't that a pretty good return? Why does it have to be a financial return?
So I have a question. As far as demonstrating the need for more physical therapy access in Upper County, do we happen to know how long patients, new patients are waiting for QH physical therapy?
I don't have it for us. I think he has capacity to bring people in. Right now he's been out of clinic a lot because of Cerner, and he's been slow in being able to build because of that. We're not marketing him because I don't know where to market this. I don't know where it's going to land, and we have to be able to make sure that we can accommodate it. And then we've also had just a rapid turnover of his support person. So he's actually been rooming patients, scheduling patients, and doing things like this in the interim. So it sort of skews how quickly he could get in, but I think he could probably get in in a week easy in that clinic.
So one of the questions when we talked with District 2 was some hard numbers on paper demonstrating the need for additional physical therapy out there. I know I see personally how it there's a full circle in outpatient, ortho, and then followed physical therapy, having access available for all of that for our community members, and that we should be meeting that need. So I don't know if there's a way to demonstrate on paper what sort of need we have.
So one thing I would say is this pro forma really isn't so much about increasing capacity, is that it's really combining the two organizations at this point. And I think Craig has signaled pretty tentatively that he's looking for an exit strategy. We are looking for a place to land. He has a really good reputation in the organization. We can find another place for our physical therapy services to exist in Cleveland and sort of do the soft competition that we currently have going with them. I do think there are some synergies here, and there's an ability to build beyond just physical therapy to speech and occupational therapy as well. So this really isn't increasing capacity as much as it is combining the two. Is that fair to say?
Yes, and also ensuring access, because I think that there is a potential that, let's say if we don't purchase this practice, maybe this just becomes a gym in the community. I don't know what the alternatives are. Maintaining access.
Okay.
Yeah.
I absolutely believe that there's no specialty services there. We are not reaching out to kids. We're not reaching out to the elderly. We don't have specialty programs that we should have in a community like that. So I think there's opportunity, but this is really about maintaining the status quo.
Like at the risk of being belligerent, if we use that logic that we wanted to see a financial return on our investment, then this tells us that we shouldn't do it, right? Because we're losing money.
I think that we can very easily make money off of this. It's an extremely conservative pro forma.
Yeah. Well,
Extremely.
I mean, it wasn't so much about the pro forma or the need to put stuff there. It was just trying to point out this is ludicrous reasoning. That the only reason you would do something is to get a financial return. If we took that reasoning, then we shouldn't do it, all right?
Right,
But
I
if they want the
understand.
services there and they're not willing to pony up any dough on it, it just seems odd that they would ask us to take a loss, a potential loss anyway, to provide services up there with absolutely no investments on their part other than just to let us lose money. Thank you. You know, I mean, we're trying to do a service there. There's nothing, there's no way to get any sort of investment in here, even to meet the Department of Health requirements. It's not benefiting the owner of the building. It's really just making it possible to service. There's no way to get anything from Hospital District 2, any kind of investment, unless we can show that they're going to make their money back.
Well, you two spoke with the commissioners directly. What was your read?
Yeah,
of
they,
this?
I mean, I think they're,
I think in a hardline sense, but that was a concern. Is that right?
no, I think they want a return on investment. I mean, that's, they want,
Well, I
they
think
want
it's
to
negotiation.
put out money and they want to receive money back if there's money to be made. Right. They had some concerns on the building, right? And then one of them had concerns that they would lose the weight room because he likes to go to the weight rooms.
And we won't, that's included in that. I would also point out that Hospital District 2 is doing their own version of strategic planning, and they do have services that they're very concerned about, like, of course, EMS is their primary service up there and it loses money every year. They're also looking at how they can leverage their existing site to encourage someone to come in and provide assisted living, which again they need up there. So they, you know, they have a set of needs that they're trying to address. We have Jim Rupture up there, I think once a week now, seeing orthopedic patients, and you know, we sort of narrowed the provider list up in Cleveland a little bit over the last couple of years. So these operations are more in keeping with the things we've been talking about. They have some other sort of services that they're looking to expand and provide.
Like, I'm not going to deprive patients of access to care, you know, because, you know, out of some sort of pig-headed. I mean, I'm not going to do that. I'm supportive of this.
What's that? So how many square
Come
feet's the
on.
building?
Pardon me?
How many square feet's the building?
I don't know if I have that at the top of my head.
32 or 3,500 for the building, the occupied space that we would.
Our occupied space, yeah, for the whole building.
For the whole building, I'm not sure.
Okay, so we'd be paying $6,000 a month for 3,200 square feet. And then to buy the practice is a extension of his contract. He would keep his accounts receivable. We're going to buy some assets. Is there
Correct.
much more to the buying
And
of the
retention bonus.
and retain? Yeah.
I feel, you know, psychologically a lot like Nat does. But on the other hand, if we do this and we combine with Craig's operation, the opportunity for us to have a strong financial return is pretty significant. So, and they won't get to share in that. So they'll be sorry. They'll be sorry. But I mean, and we can certainly afford to do this. What would we have to lay out tomorrow if we did this? If we were going to go forward with this initiative, what would be the cash that we have to lay out right away?
Right. Well, we have our functional program with the Department of Health right now, so we're hoping that they will accept that. And the modifications on the building were $150,000, the equipment 88, and those would be the cash up front. Of course, we haven't negotiated the contract yet.
Right.
These are just
So what sort of approval?
So, and let me say one more thing about PT. Everyone loves their physical therapist. This is a very feel-good service that really penetrates in the community. So, what we would be asking for is authorization for administration to take all actions necessary to transition physical therapy services in Upper County consistent with the pro forma to include entering into operating agreements with Hospital District 2, startup and acquisition costs, and remodeling expenses.
So this would be the green light to go ahead and do it.
I thought you asked for some numbers. I thought, we asked that.
Well, I think my request for numbers was to demonstrate that there was an increased need, and then there was a bit of a paradigm shift there that we were just seeking maintenance of the current situation, because if Pigeon decided, well, I'm retiring, shutter the doors, and then suddenly it's just just us up on.
Okay.
I want to say this study, that wasn't right.
It's a continuation of existing.
Right, and not only that, but I can imagine if he did do that, and then 6 months down the road he decide, okay, well, we're going to do physical therapy up there, then we don't have that automatic transfer of goodwill.
Good point.
And therapists are very difficult to find, and he has a group there that is readily employed. So that's a real benefit to the startup, I would think.
So what do you need from the board?
Well, we would vote on what she said.
You're really good at this particular.
And I'm not going to be able to repeat that from memory. Yeah, I hope you don't expect.
So,
yeah, go ahead.
So this, if we approve this, this would allow you to go back to District 2 and
say all we need is your authorization to. We're already providing physical therapy up there, but it's in the context of the RHC. So we would ask for their authority to operate physical therapy services within the confines of their district.
And then would the board hear back for as far as like if the negotiating party says, you know what, I want this much more for the building and I want better contingency, retention rate, do we hear back from that stuff, or is it just out of our hands?
What this says is we can enter into agreements consistent with what you heard tonight. I heard 140,000 and 88,000, and that's what we're asking for approval. It's something, if there's a spanner thrown in the works, we'll be back. We'll see you again next month.
Okay.
Is that correct? Okay. So at one point there was some rub about whether trade was expecting to be bought out. Are we over that?
As far as goodwill,
yeah,
we've had a discussion that we can't purchase goodwill.
So,
are you comfortable with the maintenance versus growth approach?
Yeah. I mean, I think you get paid on the building. To be honest, I mean that's 3,000 square feet, $6,000 would be good. We're going to pay utilities.
Our portion that includes, yes, triple net.
Yeah.
That's with triple net included, you said?
Yes.
So do we know what the investment commitment would be from Hospital District 2?
None.
Well, 0.
It would be their thumbs up.
0.
I mean, we're not going to guarantee any sort of return on investment, so we can just say that's
I agree that's probably the way it's going to go. It just feels like there should be more of a partnership up there, some kind of give and take, but maybe they feel like they're not in a position to.
They're trying to get 500 days cash out.
they're at 800.
They're at 800.
Oh, they're that high?
They're trying not to get 500 days cash.
Their daily expenses are under
It's
$5,000,
a
so
very
that's
small
why.
operation.
It's a small operation.
Nonetheless, that's
Yeah.
all right. Additional questions about this?
How soon would the transition be complete, do you think?
Well, we're still waiting for approval from the Department of Health on the plan. So then if we were to move ahead, we would just have to put it on a construction schedule. So
It's not a done deal. I mean, we still got a lot to negotiate.
we don't even have a contract.
Yeah.
Yeah, right. We would be approving for them to continue these negotiations, to move forward, consistent with this, but it doesn't mean it's going to happen if something happens in this Indian system.
But it does allow for it to happen within the parameters.
It allows it for it to happen if it's consistent with this.
I move that we adopt the proposal as stated by our CEO.
Okay. Second from motion made by Roy, second from Liana. Any additional discussion? Okay, all those in favor say aye.
Aye.
With a scowl. Opposed? All right, yeah, that's unanimous. Thank you.
I just want to comment
compliment Rhonda and Lisa for the good work that's been done here.
Yeah, thank you.
Absolutely.
Very helpful.
Yes.
Did you have additional things you wanted to talk about?
I just wanted to let you know underneath Home Health and Hospice that Ken Brannon has accepted the position of Executive Director of Hospice Friends. He is their former board president, and he's just excellent to work with. So I'm really excited that he's there. And Dr. Martin has had an opportunity to meet him, and he's been to our IDG team already, and he's kind of a mover and a shaker. So we're pretty excited.
What is that name again?
Ken Brannon.
Grant, G-R-A-N-N?
N-N-A-N.
Okay, Brannon.
And he used to work at Brookside Funeral Home, so a lot of people know him just from there.
How long ago was he there at Brookside?
Within the last 6 months.
Oh.
Yeah, very recent.
Libby tells me that our retail pharmacy is covering all its costs now. So they've been retail business for 6 months.
Good. Any additional questions for Rod? Thank you, Rod. All right, next, Carrie Barr.
Okay. I have nothing about physical therapy in my report. That's good. So any questions on my report out? Just have a couple things to add.
So workplace, the transfer to workplace health, that seems to be, that relationship and that pipeline seems to be going on.
Yeah. We had also, we've just had a lot of phone calls. Lisa was saying she was on vacation last week and her voicemail was packed full of just requests and inquiries, so it's
Billboards
ready.
working?
Billboards are working. Yeah.
Thank you, Michelle.
Thank you, Michelle.
Yeah, go ahead, Eric.
I had same bullet point Matt just asked about. Can you walk me through how that goes when a patient is being transferred to? How does that? Does someone call them and say, "Hey, for good news, we're transferred"? How does that go?
Sure, we worked really hard on that scripting because the word transfer is really scary for a patient, and that feels like I'm being dumped off to some other clinic. So the scripting, I don't have it in front of me, but we were really careful with the verbiage to make sure that we have a clinic that specializes in care for L&I cases. Because of that, in chatting with the primary care physician, we would like you to see Ryan R. at Workplace Health, and here's when you can get that scheduled. How does that sound to you?
Just an overall better
Yeah.
logistical
Right.
outcome.
And not as your primary care provider forever.
No, but only for
this.
that L&I
Right.
case.
And so 31 were transferred, were more than that attempted but resistant, or is that
Those,
100%?
well, we looked through the list. These were the people that we called. There were 3 that fell out just due to, wasn't the patient, it was the complexity of the case. It needed to stay with the primary care physician, but more to come.
Okay, well good, that's good news.
I'm primary care doctor, very attached to their patients, and it's really hard for them to. So 31 was huge. Yeah. Slowly prying their fingers off. They are attached to the folks they care for. So. Yeah.
Additional questions for Carrie?
The comments I have, I know you probably saw this in an announcement with Dr. Meryl Stesko. This is, it happened yesterday. It was the CDC Childhood Immunization Award that he received yesterday.
I didn't see that.
You didn't see that, yes.
Can you talking to the mic? I couldn't hear.
Oh, I'm sorry. Yeah. Okay, so this was yesterday. Dr. Meryl Stesko was in Tuckville providing a presentation. And right before his presentation, they offered him, or they awarded him with the CDC Childhood Immunization Award.
That's incredible.
It was really incredible. And then he went on into his presentation, and about the first 15 minutes was about how amazing Kittitas County is and the hospital that he works for. And yeah, it was
Wow, that's wonderful.
He's doing great work. Yeah.
He's so passionate about his revolution.
Yeah. And they called out the blog that he has. They called out the Facebook post that he puts on the community network. He's constantly advertising his presentations on there. His community talks that he does. Yeah.
Very nice.
additional questions? Oh, sorry, go ahead, Carrie.
I'm not done. I heard there was just some questions around the hold harmless for the providers, and so just their productivity.
The transition to.
Yeah, and how we have had that step. So there was a 12-month rolling average that we calculated for their productivity, and in February it was at 100%. They received a 100% amount. March the same, but they stepped down in April to 80% only, and then May 80% as well. So at the end of May, that's when that whole harmless then is released back to, they'll be back up to productivity. We're seeing, we're still trying to get the data out of Cerner to make sure we can calculate specifically where they're at, but just doing some quick temperature checks with providers and spot checking with some of the schedules. We see, like I said, women's health, they're right at 100%. They're going really strong. Orthopedics is really strong. General surgery is getting back up. The family medicine, internal medicine, about 75, 85%. So there's still just, some physicians are doing really well, others are still struggling a little bit. So we're trying to dig into that. So the ones who are doing really well, what is it that they're doing? And seeing if we can offer some sort of mentoring program or some, we're trying to be really creative with trying to help out the providers who are struggling.
Bob, did you have any questions about that?
Yeah, that's fine, yeah.
Is that okay?
I have one question about the Brown Bag review.
Yes, medication reconciliation.
Yeah, that's great, a great program.
Mm-hmm.
Do we offer patients medication disposal for medications that are deemed that they shouldn't be taking anymore? Is that something we can
Do you know if the pharmacy does?
Yeah.
No, the pharmacy doesn't, so we don't take those that patient brings.
If they're an inpatient, we would. I mean, we've got some of the dispensing things to
Or do we
do that.
provide them with information on how to do it themselves safely?
We do for home health.
Yeah.
Home health and hospice we do for those patients.
Or just general clinic patients?
Who's handling the take-back program in Kitty Fest?
The sheriff's office.
I think the sheriff's office and the sheriff's office.
I can look into that some more.
Yeah, it did. It was like a couple of
It was the shredding and the
Yes, they always do the
implementation.
shredding.
Meds are back together.
They had it last Saturday.
I mean, especially with maybe older patients or patients with dementia, once it's determined that they don't need those, it'd be really nice if it wasn't to obfuscate their medicine cabinet.
Sounds great. And then the last thing I wanted just to mention is, I keep talking about this, we have our MA apprenticeship program, and the reason we put that in place is because of the MA shortage. In Cleon, we have 2 MA positions that have been open since October, and it puts a pinch on the whole productivity. So not only are we have our first apprentice there that has started, but last week, HR representatives here at KVH, myself, and April Grant met with Charter College just to see what kind of gaps we could close between the getting some externships as well as some of the skills that they were coming when they went through their externship and then they would show up for an interview. Their skills that they had were much different than what we needed in the clinics. So we're going to look at a little gap analysis and just work with them a little bit closer to help with that.
Can you remind me, when they graduate, do they have a contract here from our MA program, or are they free
The
agents?
apprentice?
Oh, the apprentice, when they graduate, it's 1 year that they would need to work with us.
Just love that program.
Incredible, it's been very popular. We've had a lot of applicants. And HR has done a great job in creating a nice screening process that feels fair and et cetera. Okay, that was it.
I'm going to give you 10 seconds of silence just to make sure I don't think. Any additional questions for Carrie about anything on the operation? Okay, thank you.
Thank you.
All right, so Education Board reports. Roy and I are going to the Patient Safety Summit sometime on Tuesday. So we'll report back on that. Looks like no old business, New business, community relations, I guess Michelle, she's still out.
I really appreciate the way she puts her report together. So, Michelle, if you watch this. It works with my mind works.
Yeah, it's helpful.
It's very nice.
We'll let her know.
All right, so at this point, we're going to convene into executive session. How long do you think we need?
Oh, I would say an hour.
Okay, let's take a 5-minute break and say we'll reconvene at 8:30. Okay.
7:30.
No, I mean we're gonna reconvene. I meant we reconvene after executive session.
Oh,
At 8:30. But we'll take a 5-minute break and then get together for executive session.
That makes sense.
And then everyone else can come in at 8:30. Yeah, that's what I. Yeah, that's what I. Hey.
You said it's like initiative.
Yeah, but
You hit record. She said you hit record. Did you? Yeah, and then did you hit that and then log off?